Okay, hello, Sad. It's Abdullah here. So we're going to start practicing one of the communication scenarios. And the STEM
Okay.
says you're one of the orthopedic trainees and you have a female patient going for an elective total knee replacement. Please speak with the patient and address her concerns.
Okay, so she has come to the OPD or she's admitted?
She's in the clinic.
Okay, in the clinic. Okay. Okay, so should I start?
Yeah, please go on.
Hello, I'm Dr. Saad. I'm one of the orthopedic residents. May I know your name and age, please?
My name is Debbie and I'm a 66-year-old.
Okay, pleased to meet you, Debbie. So I presume you have had some issues with your knee. In short, can you tell me what those are, please?
Yeah, I think I'm planned for a total knee replacement. I was told because I had, I've been complaining of pain for a very long time, and I'm
Okay.
quite concerned about the surgery. And it's been causing me so much stress recently. I'm not really sleeping because of that. So, do you mind telling me more about the surgery? If that's all right.
Yes, sure. I'm sorry for your troubles. So I'm here to talk about the surgery we are planning to do for you. It's called a total knee replacement. Have you ever heard of it, or any of your friends or colleagues
To
went
be
through
to be
it?
honest, I just got the name from my letter that was sent to me, and I understand that are you taking all my knee out and putting a new knee in? Is that what it is?
Yes, actually, let me describe the procedure for you. So what we do in this is we make an incision, a cut at the front of your knee, and after that we expose your knee joint. This is basically a combination of the three bones, the femur, which is your thigh bone, the tibia, which is your the bone of your leg, and the patella, which is the your kneecap basically. We see all the surfaces, we resurface it, and that means we remove all the dead and uneven surface. We remove all the edges and all those things which occur due to the age. And then using bone cement, we apply some implants to replace the structures that we have removed. And those are according to your size. Are you following me so far, Debbie?
Yeah, a little bit. I'm just really concerned about the anesthetics and how long am I going to stay in surgery. How long is the operation normally?
Usually it's around 1 to 1.5 hours.
Is that in total? That is everything.
No, you will go into the OT, I think around 45 minutes before the procedure, and the procedure itself, what we do, it will take 1.5 hours. So you should be in and out in around 2.5 hours,
Okay,
hopefully.
okay, that,
Okay.
yeah,
Okay. Don't worry
okay.
if this is a bit of an information overload. I'll give you some leaflets at the end of it, and you can read about it at your own leisure, all
That
right?
that would be really helpful, Doctor. Thank you. Can
Yes.
I also ask? So I do appreciate that any surgery can come with risks. Can you tell me more about the risks that I might have from this surgery?
Sure, sure, sure. So the risks are some risks that are related to the anesthesia and every surgery itself. That could be infection to your infection of your wound. It could be unsightly scars, clots to your legs, which could, in some cases, travel to your lungs, and you could have breathlessness, and you could have some bleeding more than normal, which could require you to go some blood transfusions. Other complications are related to this surgery itself, like infected implants, or later, if the position is not perfect, and there could be some implant loosening. You may have to undergo a revision surgery earlier than usual. So these are the complications, but my consultant is quite experienced and he has done the surgery a lot of times. So you are in good hands. Uh,
Okay, fine. But Doctor, I think you mentioned so many complications. I'm quite worried now. So,
yes,
so you mentioned
there
you
are some
mentioned
rare
infection.
issues. Yes. Uh, Mrs. Debbie, see, no procedure is without risks. Unfortunately, every procedure has some risks, but the benefits of this surgery outweigh the risks, and the percentage of complications by my consultant is quite less, and I'm very hopeful that you won't suffer from any of this. There are some other also rare complications that I forgot to tell you, like injury to the nerves and arteries of the knee. But like I tell, like, these are fatal complications, but still they are quite rare. Um of course, nobody is going to force you to do anything you don't want to do. So, I could also tell you other alternatives to the surgery if you want to hear them.
Well, I'm more interested about these risks. So you mentioned the infection. Is it likely I will get infection from this surgery?
Uh, Infection rate is less than 1 to 2% in these complications in our setup. It's not very likely, but yes, it is a possibility. It would be wrong of me to say it's not likely. It's not
Oh,
probable.
okay, that's fair
It
enough. That's actually reassuring. Now, when you say that, I'm quite reassured.
Yes.
Okay, that's fine. Also, I heard about having, a blood clot. Is there any way that you can prevent this from happening or stop it
Yes,
so
yes, yes,
something happening?
yes. I
Okay.
was going to talk about that. After the procedure, we'll start you on some blood thinners. So, and apart from that, we'll advise you some physiotherapy, some stocking nets. So, all these measures are taken so that it prevents the blood clotting. You will also have to take these blood thinners for a while after the surgery, which depends from patient to patient. I would have to discuss with my consultant. But yes, these measures have a role in preventing those blood clots that I was talking about.
Okay, that's fine. And also, before the day before surgery, will I be allowed to eat? And when can I start eating after surgery as well?
Yes, you will be NPO, that is, you won't be allowed to eat 6 hours before the surgery. So that is 6 hours. And
Mm.
the if you the anesthesia will depend on what the general anesthetist are planning. So they will have a conversation with you
Oh,
before the
general?
procedure. So,
Is it
uh,
going to be general? I always thought it's going to be local or something
Uh,
else. Is
in
it
most
general?
in most in most cases, it is usually a spinal anesthesia. That is, they insert a needle at your back and inject some drugs to numb your legs. Most of the cases are done under the spinal anesthesia. But again, the anesthetist would be more better placed to talk to you about this. So if your procedure
Mm.
is done under spinal anesthesia, you will be allowed to eat as soon as your procedure is over, hopefully.
Okay. And also, will I go home on the same day, or will I have to stay
Uh,
for a bit because I need to do
no,
some arrangements?
you will have to stay for a bit. Usually for total knee replacements, we keep the patients for around 3 to 4 days. This is because of the procedure. We would like to give some antibiotics for that while. We check the wounds at around day third, and in everything is fine, and you are compiling well with the physiotherapy, and uh, things are uneventful, you could go home in around 4 to 5 days. But this presuming that everything is uneventful. Uh, if there is an issue, we could keep you for longer.
Okay. Okay, that's fine. So I probably need to arrange some time off work then. I'm not sure if you're able
Yes,
to help with that.
yes. Have to take. What do you do for a living, Mrs. Debbie?
I'm an engineer now. Sorry.
Okay, so you have to go up and about. I presume in your job.
Yeah.
Okay, don't worry. I think you would have to take some time off. Around 6 weeks for a start. We would give you a note and a medical certificate for that. I hope that would help you to get some leave from your employer.
Hmm. Okay. Well, yeah. Doctor, I'm really concerned. Will I have to quit my swimming because I'm a swimmer basically, and quite worried about this. Do I have to quit because I had the replacement?
I'm not so quite sure about that. To be honest, I haven't had an idea. I'd have to ask my consultant. I'll book you for another appointment in 1 week, and we can have the conversation with him about these things, and
Okay.
you can write down your concerns and bring a family member if you want, and
Yeah,
we'll answer all of those.
that's fine. All right. Thank you. So yeah, thank you, Saad.
Okay.
So I'm going to give you feedback now, and
Sure.
initially, there is a very important thing to say at the beginning, which is the time. So we overran by 3 minutes. Saad, can you close your mic if that's all right? And if there is anything, just open it and talk to me. All right.
Okay, just a minute.
So yeah, initially, like I said, is the time. So you overran by around 3 minutes from what it. Can you guys hear me? Hello?
Yes, we can hear you.
Okay, great. So what I'm saying is you overran by 3 minutes. I didn't want to stop you because I wanted to still cover the scenario, but you overran by 3 minutes. So what I would advise is keep your answers very short. You don't have to go through lots of fillers when you're speaking, because if you watch the video about the when we talked with one of my colleagues about how to tackle the clinical scenario and the preparation for the MRCS, your language is very important. So your language is great. I'm not saying that it needs any refining. Your language is great, and I can really understand you clearly. But what I'm saying,
Abdullah, sorry to interrupt, but communication station, we can take the whole 9 minutes actually.
9 minutes.
Yes, yes.
Oh, okay, that's fine.
I still overran it. It was around nine and a half, 9 minutes,
Okay.
34 seconds. So I still overran it, and I didn't close it properly, I think. So I would still have to make it short. Yes.
Okay, that's fine. Yeah, thanks for doing that. That's great. Great. So well, yeah. But to be honest, I didn't ask all the questions as well. There are a few questions that I skipped. So if I had to do all the scenario, we would have definitely overran by maybe 2 or 3 minutes maximum. That's one. So try to keep your answers short. So in terms of your introduction, very quickly, your introduction was good. You introduced yourself. You seemed nice to the patient, and you said pleased to meet you, which is great. So always do it this way. I also prefer when I'm doing the initial presentation. Well, I understand directly. Can I confirm your name and date of birth? Well, she say this and this. I understand you're here for some concerns regarding your knee surgery. Can I confirm what you know so far? So we are on the same page, okay? You sort of have done this as well, which is good, not bad. Then the main thing, the main feedback for you, Saad, I think you've done great in the whole scenario, but the main feedback for you is one, let the patient talk. So I tried to speak for a bit and I felt I was interrupted. So this scenario, in my opinion, the assessment is not based on how much you say, but in how you say it. Okay. So try to listen to the patient as much as you can. I was speaking about the risks and that are my concerns, and I felt like I'm being stopped. So try not to stop your patient. Let them talk. Let them finish. Acknowledge when I'm speaking. Yes, I see. Okay, that sounds good. I can do that. I can, and so on and so forth. All right. And also, when you're explaining the complications or the risks of surgery, in my opinion, this is the most tricky part of the scenario. All right. And you need to be really smart doing it. So the way I prefer doing it is to combine the complication and the treatment. By the way, these words are basically uh, um, for you, specifically for you. It's not part of the notes. I was just writing it for you. Okay. So try to combine the complication and the treatment. So the way I'm going to present the complications, I'm going to say very clearly and try to raise your voice in the important areas. I'll say, well, there are some complications related to the anesthetics, and these are all standard risks. And this will be discussed with you by the anesthetic team. From my side, there might be some complication. Obviously, there'll be a scar in front of your knee, around like 10 centimeter long, okay, or like 5 centimeter, whatever. I think in total knee it's 10 centimeter long. We'll do our best to make it good looking. However, there will still be a scar there. There is always a risk of infection that can happen in any surgery. However, we're following all the techniques to reduce that, and we can give you antibiotic on the start, which will reduce the risk. There is also a minor risk of nerve injury, muscle injury, and bone injury, which always comes with the surgery, but again, we'll do our best to avoid all the important structures. There is a risk of bleeding. It's not as high, but it's still one of the risks that we mention for the patient. And that's why I would like to take this a chance and ask you, are you taking any blood thinning medication? And then you're sort of engaging your patient with you and making an interactive discussion and not just saying all the complications. Okay. And then, however, if this unfortunate scenario happened, we can always arrange for blood transfusion, and it is something that we can deal with. Okay. There, obviously, there will be an implant in there, and any implant in our body comes with risks of having infection in this implant. And it doesn't happen very often, but if it did, we would probably have to take this implant out. But I would be surprised if this happened in early stage, but if it happened, we will be able to deal with that. Okay. So when you say that, you don't really have to praise your consultant because you don't know your consultant. And I wouldn't do that. I wouldn't say, but my consultant is very experienced and I have done this and this. I don't know who the consultant. I don't know if he's experienced. I don't know if he's around. I don't know if he's going to do it. So I'm not going to praise any consultant. All right. I'll just talk objectively from my knowledge and my information. Okay. So does it make sense, Sad, before I move on to the next step?
Yeah, I think you're quite right because
Okay.
when we tell the treatment immediately, so the patient does not waste your time. Oh, so what happens if this
Yeah,
happens? So you
exactly.
are adding
Also, yeah, it doesn't waste time, and also it gives them some reassurance, and they wouldn't ask you lots of questions later on. Okay, and again, we can talk about the pain. The pain is significantly important. I would mention it the first thing in my complications. I talked about the blood clot prevention. I think you've answered this very well. You take yes, there is a risk of blood clot, but we can keep you hydrated and we can mobilize you as soon as possible. Most importantly, you need to mention the physiotherapy team. I know, Sari, you said you're an orthopedician, but I worked in orthopedic in the UK and I had a rotation outside the UK as well. It works quite different in here. I think the main care for knee replacement patients, specifically the elective, is the physiotherapist. All the job is on the physiotherapist shoulder, literally. So after you do the surgeon disappears, and then the physiotherapist will do all the movement, will do all the exercises, and those are the people who are able to discharge the patient. So when you were asked, am I going to go home in the same day? Well, you've answered it very well, but you don't have to take long time. And always try to say, well, we do it in sort of team management. So one, the physiotherapy team will have to see you, and you need to make sure that you are on your feet before going home to make sure that you're safe. So as long as you're able to mobilize and you've done the stairs and you've got your x-rays, your pain is managed after surgery, we can send you home. We can always send you home. Okay. And also you mentioned reviewing the wounds, and you mentioned something about antibiotic. In elective knee replacement, we give antibiotic on induction, but there is no antibiotic after surgery. So try to avoid saying this. Okay, so you give an induction, you can give the gent and so on, but there is no antibiotic after surgery. Okay, so this is how I would answer the duration of stay. Well, I would say it's unlikely that you can go home on the same day. You might need to stay for a few days with us, and this is to make sure that you're safe and your home environment will be safe to accept you at this stage. And you can talk about the pain management. The physiotherapy is significantly important. The occupational therapy is significantly important. I know I was asking you questions, and these questions was time of work. I think these are things that you need to bring up instead and try to take a chance and don't make it mechanical. Try to take a chance. So, for example, I brought up early when we were talking about the risk of blood clots. So I would literally mention this in the risk factors. So when I'm saying, well, you have the risks of the surgery, include also having blood clots. Let me take this as a chance and ask you, are you on any blood thinning medication? Have you ever had any blood clots before in your body? Okay. And also, you can also use the work as as the same thing as well. So you can say, when I ask you, how long am I going to stay? Am I going to go home in the same day? You can take it as a chance. Well, do you have any commitments at home that will require you going the same day? She will say, yes, I work as, an engineer. I look after 2 kids, whatever. So you will be ready to answer this question. And you're sort of making a conversation with the patient. Okay. Well, there are a few questions that I skipped, including the walking and also including the follow-up time. So follow-up usually will be in 6 weeks, and always reassure your patient that they will have a discharge letter with them, and it will mention everything in detail and so on. Okay, I liked that you mentioned the leaflet about the surgery at the beginning. That was good, and try to keep this practice. As soon as you have a chance to mention the word leaflet, you can always mention it to them. Okay. Yeah. So overall, I
What
think.
about did I tackle the swimming question right? Because
Can
I
you say
am not
again?
sure myself. The swimming, she asked me about if
Oh,
she
yeah,
swim.
yeah, the swimming. So I think the main concern about is swimming in this patient. So, I mean, we have lots of other questions. I'm going to go through them now. The main concern about the swimming is the wound. Okay. So I don't see any reason why she wouldn't be able to swim. She will definitely be able to swim as long as the wound is dry and healed. Okay. So I would actually encourage her to keep swimming. Right? So because the swimming will keep the thigh muscles and also the calf muscles working really well, so it will make the joint a little bit stronger as well. Okay, so I will encourage her to keep swimming and after the surgery to avoid the swimming for maybe 6 weeks until the wound is completely healed and there is no signs of infection in it. So I think the main concern about swimming is the wound, is not actually the joint itself. She can ask you about driving. Will I be able to drive? Well, before the surgery, I think you're able to drive as long as you can tolerate. And after the surgery, we always advise you to take it slowly and until you feel safe that you're able to do so. But you don't really need to inform the DVLA. Okay, you just can drive as soon as you're comfortable, and it might take 1 month to 6 weeks. Traveling. So the advice is it's not recommended at least 3 months after the operation because of the risk of having blood clots, longer flights. You can say for the longer flights, it should be avoidable. But if you're doing any domestic travel, going from a city to another, you can always use the train or use the car with someone else driving you. But it shouldn't be more than 3-5 hours or maybe 2 hours per day. Okay. And you can also give an advice. You can also keep your muscles active and working all the time. And then at the end, after we finish everything, you can summarize. Well, so we talked today about the surgery. I counseled you on this and this and this, and you need to be fasting before surgery, and so on and so forth. If you had time, and this is what I would prefer, and this is what I would do in clinic. If you had time, try to take history from the patient. Okay, and the history need to be very quick, and you can make it in between. So, for example, the history. Well, just let me. For example, I can also take it as a chance in that question. Remember that question about what time I will go home. So this will depend on your clinical condition and your recovery from the surgery. And let me take this as a chance. Do you have any medical condition at all? Do you have high blood pressure? Do you have, diabetes? Do you take any medications? Any allergy to anything? Have you had any problem from the anesthetics before? Literally, you're asking all the questions with yes and no answer. It wouldn't take you like 10, 20 seconds to ask like 4 questions. Okay, so I would take this as a chance. So what I'm trying to say here, make this as a conversation and not a one-way or a unidirectional conversation. So try to make the patient speak and say more things. Okay. The last thing is for you, Saad, when you presented yourself, you said you are a resident. A resident is some sort of North American concept that doesn't exist in the UK. So just to try to say, so I told you, you're one of the co-trainees on orthopedics meeting a patient in clinic. So present yourself that you are one of the core trainees or one of the orthopedic trainees, one of the SHO. Try to use the terms in here because, I mean, to be honest, it's not significantly important, but it gives the examiner an idea that you know how the system works in here. It's not going to affect your results that much, but affect the impression, which might, in my opinion, affect the result, if that makes sense. Okay. All right. I think that's it for the total knee replacement. And thank you, Saad, for participating. Do you want to add anything, Saad?
No, I think yes, you're right. In a lot of things, I learned a lot. Thank you.
Yeah, that's great. Is there anyone else want to practice? We have 5 more people. Is there any one of you want to practice? Okay, that's absolutely fine. I think I'm going to cancel the meeting now. Yeah, Bidad, I'm sorry if I'm saying your name wrong, but are you able to open your mic?
Hi there. Yeah, I'm over here.
Hello, you right?
Hi, can you hear me? Yeah.
Yeah, I can hear you very well. Do you want to practice?
Sure, of course. Go
Yeah,
ahead.
before that, when is your exam?
It's August.
August, okay. And what's your background?
I am a graduate of medical school. I assume it's called in foreign countries as general practitioner, but I assume it's pretty much different in United Kingdom, right?
Yeah, I think so. But what's your background in terms of a specialty? What's your specialty?
As I said, I'm a general practitioner. I
Okay.
don't have any specialties yet.
And are you taking you're taking the MRCS to be a surgeon? Is that correct?
That's correct. Yes, sir.
Have you had any surgical rotation before in your internship or your foundation, anything like that?
Yeah, I spent about 6 months in
And
surgical rotation, different surgical rotations.
is it general surgery, neurosurgery, urology? What was it?
It's more of general surgery, ophthalmologic surgery, and no, definitely not neurosurgery or urology and no orthopedic surgery.
Okay, that's absolutely fine. So let us start with you. You have a 55-year-old male patient coming to you with jaundice. Would you like to take history from this patient, if that's all right?
Yes, sir.
Okay, go on.
Hello, good morning. My name is Badad Namiranian. I am one of the core trainers doctors. May I know your name and your age, please?
My name is Abdullah. I'm 55 years old.
All right, Mr. Abdullah. How would you want me to call you?
Abdullah is fine.
Abdullah. All right, Abdullah. It's very nice to meet you. And may I know what have brought you to the clinic today?
Yeah, doctor. To be honest, I don't know. A few days ago, my wife told me that I'm getting more yellow in color, and my urine looks really dark. It's like tea. So I'm really worried. What's happening to me?
Uh-huh. All right. So could you tell me when did it start?
Well, in terms of my color, I've been getting these comments from my colleagues at work that I'm getting a little bit yellow in color and a little bit darker for like a month now. But I didn't care, to be honest, until like a few days ago. My wife told me that everything is a change. But when my urine turned into a tea color, I was so worried. That's why I came in here.
All right. So could you tell me if there is any pain in your tummy or any other sign and symptom that you know about?
Yeah, I do have actually I do have some pain on the sort of like around my chest on the right side or the lower end of my chest.
All right. Is it just there or it just radiates to any other adjacent areas?
Well, I don't know, but it's sort of dull pain in this area and also in my stomach as well. And I feel as well that it might be in my back as well. I don't know, but it's mainly in my stomach. It's very sort of discomfort. I'm very discomfortable all the time.
Oh, I understand. And I'm sorry, so sorry that you're experiencing this pain. Could you tell me on a scale of 1 to 10, how would you rate the pain, 10 being the highest?
Well, I would say it's a 5 or 6. It's not so severe, to be honest. Just some dull ache and pain on my stomach.
And is it possible for you to tell me how it has interfered at all in your life?
Well, it's just the comments about me turning into yellow and the urine as well. This is what really bothered me. But the pain, I always had pain. But yeah, it's just getting worse. But I don't know. I'm just getting worried about the color and also the urine color as well.
All right. Do you have any cough, any vomiting blood, or any other sign and symptom that you may
Not at
want
all. No, I'm fine.
All right. Could you tell me, are you diagnosed with any other diseases?
Um, well, no, I'm not diagnosed with anything, but I just want to say that a few years ago, I was in an alcohol rehab, And
Sorry,
yeah,
I just lost connection. I just lost connection a little bit. Could you go back again?
I'm saying is that a few years ago, I was in alcohol rehab because I was an alcoholic, and then I
All right.
stopped. But to be honest, I was under so much stress recently, so I started drinking again.
All right. Have you visited your GP regularly, and is there any comment from him?
Well, no, I didn't visit my GP, but I remember I got a letter because I mean, I did an ultrasound on my liver. I think that was around a month ago, and I got a letter from my GP saying that I do have some stones in my gallbladder as well.
All right. All right.
Yeah.
Do you take any regular medication or any or counter
Yeah,
medication?
just the painkiller. I don't take any other medication at all.
All right. And the painkiller is to address the pain that you're just telling me, right?
Yeah, just a paracetamol, these kind of thing.
Oh, all right. All right. Is there any other diseases running in your family?
Well, just the alcohol in the family, really, but no
Uh,
disease.
I understand. And if it's okay, I want to just ask you some personal question. Do you smoke, sir?
Oh, yeah, I do.
Could you tell me how many sticks per day and for how long?
Oh my God, that's been ages. I smoke like 20 a day for years now.
Uh-huh. And I just want to quantify how much of alcoholic beverage you drink. Could you tell me
Well,
how much you drink a day?
to be honest, I've been off alcohol for around 2 years now. But I came back. Maybe I got drunk last week by one bottle of wine, and that's it.
I understand. Could you tell me if you possibly use any recreational drugs?
No, not at all. No, never tried this before.
All right. And generally speaking, do you consider yourself a physically active person and do you exercise regularly?
Yeah, a lot. I don't exercise, but I'm physically active person.
All right. I just want to go over all the system in your body, and it may seem irrelevant, but it is important to us. Have you ever experienced sudden blackout?
No, never happened before. Just from the alcohol, really, when I drink too much. But for 2 years now, this has never happened.
Oh, all right. So, any headache, any blurry vision, double vision?
No, not at all. I'm fine.
All right. Any nausea, vomiting, coughing up blood, vomiting blood?
No, no.
All right. So, any change in your bowel habit, any weight loss, any change in your
No.
appetite?
No, I think I lost my appetite since I had this pain, but other than that, I haven't lost weight. I'm fine.
All right. Any burning sensation during urination or anything else that you want to tell me about it?
No, it's just the color of the urine that has a change, but there's no burning sensation.
All right. All right. So I think that's pretty much it. So, Abdullah, I believe you're suffering from a condition
It's
that's.
fine. You're done with your time, so can I start moving on asking you questions, and then we can go through feedback? Do you want to present your case?
Yes, sir. So I saw Mr. Abdullah, who's a 55-year-old gentleman, presented to me with a 1 month history of progressive jaundice, which has been worse over the past few days. And he also complained of some dull pain in his upper abdomen or lower chest area, which radiates probably to his back. And as I realized, there is no other sign, any other associated sign and symptoms. The family history and social history and past medical history is somehow irrelevant, other than he used to be an alcoholic, which has been out of drinking for the past 2 years, and he started again recently. I think that's pretty much it.
Okay. What's your top differential diagnosis?
So I'm thinking of gallstones that he had the liver ultrasound before, obstructing the biliary tree, and I believe he has obstructive jaundice because of the gallstones. My other differential diagnoses could be hepatitis and most probably alcohol hepatitis. Yes, that's the most important differentials that I have.
Okay, it sounds good. And what would you like to do next for this patient in terms of investigations?
Sure. I'm not really sure the liver ultrasound was done how many times, how many years, or how many months ago. I would like to request an liver ultrasound, abdominal ultrasound, as well as a routine blood test. Also check for the hepatitis B or C virus. I would like to request the AST, ALT, and that's pretty much it. Yep.
Right. That's fine. Thank you very much for your time. That was great. Yeah, so let me just start sharing my screen, and I'm going to give you feedback. So first of all, I like your energy so much. You have so much energy, and you sort of like passionate taking the history, which is great. But there are a few things that we need to work on really. So starting by your history presenting complaint is perfect in terms of covering as many symptoms as you could really, and is very smooth as well. You were very smooth in asking all the questions. I didn't feel that you were thinking too much on what to ask next. So you were sort of like you had the flow and you asked all the questions very well. Okay. You've done an assessment of the jaundice. You've done an assessment of the abdominal pain. I think you did not ask about the fever, which I think is very important because of thinking about ascending cholangitis. Okay. And you asked about all the associated symptoms and the systemic symptoms as well, very well. Okay. You asked about weight loss, anemia, lethargy. Maybe you could have added night sweat and night fever and so on. But otherwise, I'm very happy with covering all of this. But the only thing I would say is fever, to cover the fever as well, thinking about ascending cholangitis. All right. That's the only effect in here. The main thing as well, when I mentioned to you here, when you asked me, well, I'm really concerned about my urine color, I said this sentence around 5, 6, 7 times during the consultation. All right. So take the chance and try to address my concern and say, well, yeah, that must be really worrying. However, we will do our best to try to get to the bottom of it and find the reason, and hopefully we'll get you sorted. Right. So you're sort of giving me some sort of reassurance that I'm in good hands and I'll be moving forward to improvement. Okay. Good. And then, so I always say, take history of presenting complaint. Next thing you do is differential diagnosis. So your differential diagnosis, like you said, is alcoholic hepatitis, and you took very good alcoholic history. It's gallstones, and also, viral hepatitis, recent travel. You can ask about all of this. This is the main differentials. But in this particular patient, you're concerned about, in my opinion, I am concerned about 3 things. Okay. One is acute pancreatitis with the character of the pain that the patient have, or gallstone pancreatitis with him having background history of gallstone. So one will be acute pancreatitis. 2 is choledocholitis, or it's a gallstone on the common bile duct, okay, with ascending cholangitis. So these are the most 3 things that I will mention first. But I'll take this a chance to give you a feedback on your presentation. So when you're presenting a case, the examiner has been there all the time. He listened to you. He listened to your patient. He knows what you've done very well. So in my opinion, the presentation needs to be really short, from 30 seconds to 1 minute maximum. All right. And you're selling a diagnosis to your consultant. In what sense? So in this patient, let's say I'm thinking it's acute pancreatitis or gallstone pancreatitis with choledocholitis for obstructive jaundice. So the way I present, I've reviewed today a 55-year-old male patient with a presentation of obstructive jaundice that is most likely gallstone related, in addition to acute pancreatitis that is gallstone related. So he's 55, presented with jaundice, progressive, it started a month ago, has gotten worse. There is a change in the urine color and the stool color as well. We could have asked about it. There is no weight loss. There is no any alarm symptoms. It doesn't have any fever, so I am not concerned about ascending cholangitis at the moment, but I will confirm this with doing further investigation. That's it. See, it's very short. I didn't take more than 1 minute to present the whole case. You don't have to go through the whole thing. You don't have to go, he's a non-smoker. He hasn't done this. Well, the examiner know that you asked all of this. If you managed to finish everything in less than 1 minute, great. If you didn't, just make it short and sell your diagnosis. So here I'm selling my consultant acute pancreatitis, ascending cholangitis, and also or cholelithiasis and ascending cholangitis as well. All right. Otherwise, you covered past medical history quite well. You covered drug history. I think you didn't ask about drugs. I'm not sure if you asked. I might forgot. And also occupation. You didn't ask about occupation. Family history. The other thing I will add, which I even didn't mention in my note, is ICE. Ideas, concerns, and also expectations. Right? So you could have asked me, I showed my concerns many times, and when I show them, addressed them. So I said many times, I'm concerned about my color and my urine color. You can ask me, what are your ideas? What do you think this could be? Well, I'm very worried it might be cancer. And at this point, you might reassure me. Okay. Well, I asked about investigations. I think you need to work on your investigations a little bit. So investigations, we always classify it into bedside investigation and bloods. For any general surgery patient presented with abdominal pain, you need to get a few investigations for them as bedside. If it's a female, get a pregnancy test for them. If it's a male or a female less than 65 years old, get a urine dip for them. If they have pain in the abdomen, get an ECG for them. Okay, get an ECG for them as a bedside. If they have pain in the lower abdomen with decreased urine output, get an ultrasound or a bladder scan. So these are the 4 investigations that you can get as a bedside. All right, so ultrasound and urine dip, pregnancy test as a bedside investigation. And also bedside, you can, and the ECG obviously, as bedside, you can always do an observation for the patient, measuring the blood pressure and, measuring the temperature and so on. These are bedside investigations. And then you move on to the bloods. For any single patient presented in general surgery, presented with abdominal pain, you need to get all the routine bloods. This is FPC, looking at the inflammatory markers and the white blood cells and the neutrophils and the hemoglobin as well. CRP, that's again inflammatory markers. UNE, looking for the kidney function, for any drop of the kidney function or having sepsis. Okay, and liver function test. Those are the 4 routine investigations. Are we done with bloods? No, we're not. There is lots of other bloods that we can do, and that will include the amylase, significantly important for every single patient. All right, with abdominal pain, and particularly this patient because he has a central abdominal pain, radiated to the back with right upper quadrant pain, and background of gallstones. This is the commonest cause of acute pancreatitis. Gallstone pancreatitis. Okay, so amylase is extremely important. All right. What about bone profile? Bone profile again is important because it's going to give you the alkaline phosphatase. The alkaline phosphatase can come under the liver function and also come under the bone profile. You need the alkaline phosphatase to define if this is a hepatic source of jaundice or a post-hepatic or an obstructive jaundice. Okay, so alkaline phosphatase or bone profile as well. And also, if the patient liver is affected, you will be worried about bleeding because the liver produces lots of the coagulation factors. So you need to ask your patient in the history taken if they have any blood, which you did, which was great, and also to do Groven screen, cross-matching, and coagulation profile in case they've lost blood. I mentioned till now 9 different bloods. So always remember, it's a 9 different bloods in general surgery patient. Groven screen, coagulation profile, cross-matching, they go together. And then the 4 routine, FPC, UNE, CRP, LFT. And then get bone profile to get the alkaline phosphatase and the amylase. When you count them, you'll find them 9 bloods. Okay, And then you can add the imaging, which you just jumped to the ultrasound. I wouldn't jump at the first place. I wouldn't just jump very quickly to it. I will mention the bedside first, and then the bloods, and then I'll move on to the imaging. Abdominal imaging, we have very limited imaging that we can do in the abdomen. You have the ultrasound, and the ultrasound is an amazing investigation to look for a fluid-filled cavity. Any cavity that has fluid inside it, the ultrasound is amazing to look at it. And that gives you the gallbladder. It's a cavity that has fluid inside it. Patient who has an abscess, it's a cavity that has fluid inside it. You know, a patient who has a hernia, it's a cavity that's getting outside and has some fluid or secretions inside it. Okay, so ultrasound is amazing. That's why you can do as well for, you know, the duplex ultrasound, or, you know, Doppler for a peripheral vascular disease, because it's an ultrasound and it's looking in a cavity that contains fluid inside it. Okay, so ultrasound is amazing in that sense. So in this patient, ultrasound could be the best investigation. However, if it's not available, you can always get a CT abdomen pelvis with contrast. So these are the two common investigations that we use in the abdomen. Abdominal X-ray is almost always is almost never the right answer in the abdomen. It could be the right answer in orthopedics, could be the right answer in the chest, but in the abdomen, it's almost never the right answer. Okay, great. So we can get an ultrasound / CT abdomen pelvis with contrast. Okay, finally, I can also get, based on the results of what I just ordered, I will decide if I need an MRCP or an ERCP for this patient. So these are all the investigation. To summarize, I will answer the question in 1 minute now. Please time me for 1 minute. I'll mention to my consultant, I'm going to answer now. So I would classify my investigation into bedside investigation, bloods, and some imaging. In terms of the bedside investigation, we'll get an ECG for the patient, can get a bladder scan, urine tip. And in the bloods, I'll get the routine bloods, FBC and CRP, to look for the inflammatory markers, and liver function test and bone profile to look for the obstructive jaundice or hepatic jaundice. I'll also get an amylase because I'm worried about acute pancreatitis, and I'm worried about the bleeding disorder. I'll get a coagulation profile, group and screen, and also cross-matching for the patient. In terms of imaging, ultrasound will be my first investigation, looking for gallstones or dilatation of the intrahepatic and extrahepatic bile ducts. If it's not available, I can get a CT scan, but the ultrasound will be the right investigation to do. Based on my findings, I'm going to move forward to do an MRCP or an ERCP, but I wouldn't decide until I have the results. Does it make sense, guys?
Of course, yes. That's very awesome. Thank you so much.
No worries at all. But I mean, generally, you've done very well. But I think you mentioned that you're a GP. Try to get more practice on general surgical patients, or maybe in more surgical patients, because that will really help you. Your history is really smooth, which I really like. So let's say if you're my foundation doctor working with me, I'll be very happy with your history. We're going to do a little bit of modifications, but I'll be very happy with your history. All right?
Thank you so much, sir. Thank you.
Yeah, thank you. All right. So we have anybody else want to practice before I move on? Okay. So now I'm going to Saad.
Dr. Abdullah, how much did the last history taking take? How much time?
To be honest, I didn't keep track, Saad.
But
actually,
I think I have noticed something that these kind of stems, especially jaundice and abdominal pain or neck lump and dysphagia, they have a lot of questions, and if you ask all of them, they inevitably cross the 6-minute mark. So it's really difficult to comprise everything within the 6 minutes without sounding interrupting or being rude to the patient.
Yeah, I mean, what I'm trying to say to you is, to be honest, you don't have to be perfect in the history taking. It's all about the process and how you do it in the exam. I mean, I'm not sure if I mentioned this to you before, but I work as a teaching fellow, and we do exams for medical school all the time. So we don't really care. The data gathering is important, but only the crucial data gathering. So I think in this history taken, I would focus on very quickly the pain. I wouldn't ask all the Socrates, where is the pain? Does it go anywhere? That's it. I don't have to grade it. Is it severe? How is it prescribed? I don't care, all right? So it'll be just very quickly, where is the pain? Does it go anywhere? Do you have pain in your chest or not? Do you have any vomiting? Do you have any distension? How is your bowel movement? And then I'm going to move on to the jaundice. When did it start? Is it increasing? How do you notice it? What is the color of your urine, color of your stool? I think those will not take like 3 minutes of my time. The presenting complaint, all right? Past medical history, I wouldn't take too much time. Do you have any medical condition? Do you take any medication? I know the patient will have questions. They will interrupt you. It's all right. They interrupt you for a reason, because literally, like I told you, when I do the exams, I tell the patient specifically, interrupt them, put them under stress. And I would like to see how they answer their questions, if that makes sense. So I would like them to interrupt you while you're taking history. So if you started to respond, well, ignoring her, you're going to lose marks. If you started to interrupt her, you will lose marks. But if you listen to her and you didn't gather the information, it's fine. You will have the mark, if that makes sense.
Yes. Yes. Thank
Okay.
you so much.
So like I said, I mean, I know you were really worried, sad in your scenario, and you interrupted a few times. But I would advise, do not interrupt, just listen, and don't worry about the data gathering. As long as you're doing the absolute minimum of data gathering, which is the minimum is the important things, I think you will be able to crash out. Okay. Okay. I think
Okay.
that's it. That's it for today, and I'll see you next time.
Thank you.
Thank you.
Thank you so much. Thank you. I have just very quick question. When we are taking histories in the station, will we be provided with a pen and paper to write down the maybe signs,
Yeah,
symptoms?
I think you can be provided, but I wouldn't advise to do that.
All right. Thank you so much.
I would advise just to use your communication skills, because like I said, the data gathering is not important. If you use a pen and paper, you will lose half of your communication, which is your eyes and your arms and how to speak and so on. All right. So never do that. Just to get used to just asking questions and depend on your memory and memorizing them. Even when you're presenting, I know you might be worried. Oh, I'm gonna miss a few things. Even when you're presenting, if you missed a few things, it's not a problem as long as you covered most of the important stuff. And like I said, your presentation basically depends on you're selling a diagnosis, a certain diagnosis to your consultant. Okay.
Mm-hmm. I understand.
Thank
you so much.
Thank you. Have a good day. See you.